crucial tips and tricks on the use of robotic eTEP TAR combined with Dysport botulinum toxin A injection for managing complex and loss of domain ventral hernias. Complex ventral hernias are defined as those with a size larger than 10 centimeters and where the hernia content exceeds 20% of the abdominal wall volume. Our 5 cases meeting these criteria exhibited abdominal wall dysfunction and pain. The largest defect in our series measured approximately 14 centimeters in width, with the hernia volume constituting 63% of the abdominal volume. Preoperative preparation. Patients underwent Dysport injection 2 to 4 weeks prior to surgery. Operative steps and tips and tricks. 1. Approach selection. This depends on the hernia's location and the presence of any scars. 2. Patient positioning and port placement. For the bottom-up approach, the legs are positioned low to prevent robotic arm collision with the patient's legs. In the top-down approach, the barrier is lowered to avoid camera collision. Preoperative ultrasound is routinely used for port placement design. 3. Space creation and sac dissection. The midline is crossed laparoscopically, followed by docking the robotic XI system with 3 arms and one 8mm assistant port. Retrorectus space creation preserve the linea alba by cutting 0.5 to 1 centimeters below it. Right and left retrorectus spaces created. You can clearly see the linea alba reflection and arcuate line. For large chronic irreducible content with insufficient pace for reduction, perform adequate space before content reduction. During sac dissection and content reduction, decrease pressure to 6 to 10 mm Hg for better visualization and handling. Merging TAR, both top-down and bottom-up, is helpful around the arcuate area. Follow the muscle plane and cut proximal to the transversus abdominis and posterior limb of the internal oblique aponeurosis. Cut the intermediate fascia. Then enter the Bogros space from bottom up. Bilateral TAR was performed. Close posterior peritoneal defects with absorbable VLOC 2.0 sutures. 5. Primary fascia closure. Non-absorbable VLOC NOBER 1 sutures and partial sac plication for intracorporeal traction and to ensure an average tension of the suture line. Tips: the video demonstrates techniques to manipulate long barb sutures. To avoid accidental cuts, use the tip of the megasuture cut needle driver and needle instead of grabbing, with pressure stepped down to 10, 8, and 6 mm Hg. For long scars and defects, use an additional port through this and retarget the robotic boom to the opposite side for adequate TAR and proper fascia closure. Retarget again to complete fascia closure. Six. Mesh placement. Cigarette gauze is useful for making a mark. Place a large piece of uncoated mesh in the entire created space. Tip: ensure the mesh is adequately spread out to cover the defect completely. A 15 FAR JP drain placed for 1 to 2 weeks. Outcomes. Combining botulinum toxin A with the robotic eTEP TAR technique has increased fascia closure rates. Patients reported pain scores of 2 to 3/10. All patients experienced rapid recovery and ambulations. Follow-up. In the short term, patients have recovered abdominal domain and function, reported no abdominal discomfort, and have not required painkillers. Thank you for your attention.